Hi.
Not a problem. Okay, we are now recording. Hello, everybody. I would thank you for coming. We're going to do a little presentation on COVID, and we're speaking with my good friend here, Hilbert Bryce, which I like your last name, by the way.
Well, thank you. It's feelings mutual.
Hilbert is an ICU nurse at a hospital, and I'll go through his biography here in a moment. In fact, why don't we just move on to that? Move past that. Here is Hilbert's, nope, go back. Here's Hilbert's biography. He's been a registered nurse longer than I have. He trained at Alberta. Is there anything you want to add to that, Hilbert?
No, I think that covers it all. I've essentially worked in every part of the hospital that one can think of. It's all I've ever done. It's all I know how to do. I've never done another type of job, ever.
Kind of, does it run in your family? I understand. Isn't your daughter a nurse also?
My eldest daughter is a nurse. She has a master's. She's a nurse educator. She also an ICU nurse. And my son is also a nurse. He works in the emergency room at UCSF in San Francisco. He's a emergency room specialist.
Wow.
Well, he has done, and he loves doing that. And yes, and their mother is also a nurse, and she also works at UCSF. And she also works in the COVID unit as a medical surgical nurse up there.
Very cool.
Yeah.
Oh, I'm sorry, I blacked out your screen there for a minute. Now I got you back. The topics we're going to talk about today, we're just going to basically go over this list, and Hilbert's going to tell us about what a typical day is like, what type of symptoms they get from the COVID patients, what kind of treatments they're using, the current view among the other staff on testing, and any other side effects or such you might have seen as a result of COVID. So, but before we start on that, Hilbert sent me this wonderful newsreel. This is his unit at the hospital, and I'm going to run that for you. It's only about 6 minutes long.
Volume?
I can't hear it. I don't know if anyone else can.
No volume, Bryce.
Yeah, let me see if I can raise the volume on it.
This gentleman is the head of our respiratory department.
Let me stop it just a minute.
Okay.
I will stop the share and see if maybe if my computer, if I can raise the volume.
Also, I do.
Okay, my volume is at max.
There should be an option for you to also share audio. I can't tell you where it is because I can't see it right now on my screen, but there should be an option for you to share audio as well as share screen.
Okay, I'm going to go back into the full screen. I'm going to pause the recording here for a minute. Okay. Audio, video settings. Is there a setting somewhere in Zoom?
I think so. I can't remember exactly where it is right now, but I've had this problem before sharing videos on Zoom, and there is a place that you can
look
share.
for the option that says share your computer audio.
I'm glad you have some tech-savvy young ladies in your class, sir.
Yeah, I'm glad. Okay, here's an audio. I'm going to go with the audio. Here we go.
I'm just too old for all this.
Okay. There's the audio. I don't know.
When we tested it last week, it came up.
Yeah, did it sound okay last week when we ran it, Hilbert?
Yes, yes, it did.
Okay, I don't know. Let me try advanced. I don't know.
Okay. Does Zoom have a setting? Drop down?
Yeah, that's what I'm in right now. I think we might just have to roll with it, and then
Yeah, I could discuss a little bit about it.
okay, why don't we do that? So I'll go back to share screen.
I think it's when you share your screen, Bryce, when it gives you the options. There's like share your desktop and then there's share like a video and audio.
It's right there, share computer sound. Okay, let's try this again. I'm going to, we are recording again. Okay, let me go ahead and bring the screen up, share computer sound. Let's try this again and see if we can hear it better.
Drew, thank you. New at 6 tonight, the number of patients.
Sorry, that was me.
Drew, thank you.
Can we hear it
New
better
at
now?
6 tonight, the number of patients at Salinas Valley Memorial continues to grow. They're now in the process of evaluating if opening a third COVID-19 unit is necessary. The hospital gives us a glimpse of what it's like inside, and the healthcare workers there are asking people to continue taking this virus seriously.
We're just going to go with the vent protocol for the time being.
It's hard to hear the glass sliding doors close, but this is how doctors and nurses are forced to communicate sometimes.
Are you there, Hilbert?
A patient's vitals is written on the glass.
This is devastating. People are losing their lives. Really, what I really want people to know is that this really is not a hoax. We are not being fearful of this disease. This is a serious virus, and it's very contagious.
The numbers in Monterey County continue to grow, surpassing 3,500 confirmed cases this week. One unit alone requires a full staff that is working around the clock to help save their patients. Still, they're fighting a virus that has no cure.
Currently, we had a guy that had some respiratory failure. We've got him intubated. The doctor's putting in a central line, triple lumen central line. And then after that, the respiratory therapist will put in an arterial catheter to monitor the blood pressure. And we'll just monitor the patient from there.
The healthcare workers are also making sure they are protected with layers of PPE.
You ready? Okay.
Inside the ICU rooms, they are covered from head to toe.
We went to school for this, and we know that we're going to be doing this. So I don't think that we're heroes. We just have to do what we have to do.
And that is making sure that they help their community. But
I want to pause this just a moment, Hilbert, to ask you a question.
Yes.
Now, and you've mentioned, it showed here in the video, you had several nurses inside. Let me back that up a little bit. You mentioned to me that how many nurses does it take care of one COVID patient?
In this particular scenario room, they are actually intubating. So it's taking about 2 nurses, the doctor, about 2 respiratory therapists, and the nurse outside. So approximately 4 to 5 people in the room. And the difficult intubation, it could be more nurses, could be more nurses.
Because I know you mentioned that you don't, a lot of people in isolation, we just walk in, put on the gown, do our thing, and walk back out again.
Right.
It's a lot more strict on COVID.
So in each patient, each person in there are wearing 2 sets of gloves, 1 gown, goggles, and we only use well, not only, we use them at any time we need to for longer periods of time in the room. The PAPRs, the yellow headgear, that's the portable breathing respirator. And we wear them for all intubations and all longer cases or lengthy times in the room. Otherwise, we just wear N95s with goggles or face shield for care, plus 2 gloves, a mask.
Oh,
and there's
okay.
a protocol for putting the gloves on, a protocol for removing the gloves, and there's a buddy nurse outside often to make sure that sequence is being followed.
Wow. I remember using a PAPR with tuberculosis patients.
Right, so it's very similar to that, exactly the same reasons we use it for that.
Okay, I'll continue.
They're very light and they're very comfortable, and you feel very, very safe with them on.
Good, good.
The ICU rooms, they are covered from head to toe.
We went to school for this, and we know that we're gonna be doing this. So I don't think that we're heroes. We just have to do what we have to do.
And that is making sure that they help their community. But in return, these COVID-19 nurses want people in Salinas to help prevent further infections.
Not having parties, which we've heard a lot about, you know, the family gatherings of just because they're family does not mean that they're not contagious and spreading the virus. So I please wish that everybody would take this seriously and protect themselves.
The first COVID unit had a 14-room capacity. The second has 13. At Salinas Valley Memorial Healthcare System, the most patients they've seen is 26. The hospital now considering opening a 3rd unit. And you heard those nurses, they're so compassionate and humble, saying they don't consider themselves heroes. Still, you can help them, they say, by...
Oh, I'm sorry. I cut her off, but
that was about it in a nutshell. What the nurses are doing and what they look like doing it.
Okay. Well, let's jump into the first question, Hilbert. Just go ahead and explain. I mean, a typical day. I'm sure a lot of us walk into an ICU and do our thing, but this is different.
Well, let's do a little transition. We have all the patients on that unit. The patients who are needing basic care, they're not yet ICU nurses. They're needing symptomatic supportive care for fevers, muscle pain, and cough, and being treated with Tylenol and supportive measures for fever and for pain and oxygen. And things have transitioned from the beginning, and things are still evolving. From at one point when they got to 6 liters, we would intubate. That was about a month or 6 weeks ago. Now we're trying to intubate wait as long as necessary to intubate. So that's evolved, a change that has evolved. So when they evolve and they need more oxygen, their oxygen saturations, we cannot get them above 80%. Their breathing has become stacked, their abdominal breathing, and then we begin to consider need for ICU and intubation and ventilation. At this point, considering they've been ventilated, on the ventilator, supportive care being sedation via intravenous sedation using the common drug propofol, Diprovan, as we know it initially, and get them comfortable and supporting their blood pressure, needing pressors if necessary. At this point, they are very symptomatic of beginning of possible sepsis. Sometimes with intubation, they can aspirate. So, and if we know they have aspirated, we begin a protocol of antibiotics. But essentially, this is what they are. As we come on and shift first time in the morning, the nurses give report. But first of all, they consider who the patients are. Many of our patients have been, not necessarily all of them, patients who work in our agricultural, some at different levels, some at the field, some at managers, some at, so it's not just field workers, but some are compromised, living in homes with family. We establish whether they speak English or not, even though they are intubated and sedated. We like to always talk and discuss and tell the patient what we're doing regardless of how sedated they are. So we hand off knowing the type of patient, their social problems, and whether what their family situation is about, so the nurse knows. Whether they do not resuscitate, if they tend to be, if they have many comorbidities, the families may, after the doctor spoke to the family, they may want to begin a do not resuscitate. It doesn't mean we're not treating them, we treat them actively. And if they do go into serious trouble, then we will not resuscitate them. But at this point now, we will consider also if they're paralyzed, if we have to use a paralytic, if we have to use, and they're also on continuous pain medication and morphine via morphine PCA machine for pain. And sometimes we use Nimbex for paralyzed. It all depends on how difficult it is to oxygenate the patient. That's depending on how much sedation they need. And the more sedation will keep the patient, we will be able to ventilate them easier. At that point, the different levels of need, if they need to be proned. So all these things we discuss first thing in the morning. So the nurse has to manage a day planning not to be in the room more often than he or she needs to be. So you take everything you need into the room, whatever drips that may need to be. Normally a drip may run and expire or run out. You will go in the room and just change it while you're in there, even if it's a little bit left, and things of that nature, just to reduce the time spent in the room.
Okay.
The buddy nurse.
You kind of touched on this, which is why I moved ahead. As you were talking about respiratory patients, I've noticed just in looking at things that most of these patients are on their belly. And to be honest with you, 20 years in the field, I had never seen that before.
Well, yes. And we're starting to put them on the belly even before they're ventilated. Even when they're on the medical unit, there's what we call self-proning. It increases the ventilation. It just it makes the part of the lungs that's higher up gets more oxygen, and the alveoli are open easier. So that's why we will prone them, and they about 16 hours, but they get turned between every 2 to 3 hours in a prone position. Being on the bellies, meaning prone. It just helps to increase the blood supply, therefore increasing the oxygen supply. So it all depends on the oxygen demand.
So they don't stay on their belly necessarily, you're rotating.
No. We'll do a prone for between 16 max to 24 hours period, sometimes longer, sometimes shorter, depends on how they respond. And sometimes you have to have them paralyzed to be in a prone position because you have to have their limbs and protect all their bony prominences with soft pillows and the like as they're prone, and we have to protect their face from getting pressure sores, and moving the tube has to be, it's a bit of a process to have a ventilated patient, intubated patient, to have them prone. We have to protect them enormously.
I bet that'd be really difficult.
It is.
They're literally laying on their tube.
It takes the respiratory therapist and 2 nurses, sometimes more depending on the size of the patient.
Did you have a question, Bosna? Okay. We'll move on.
Is it the Zoom that I'm supposed to join?
Oh, yes.
Oh,
If you have a
I'm in
question,
the right
that's fine.
meeting, right?
Pardon?
Am I in the right meeting?
Yes, you are.
Yeah,
You're in the
okay.
right place.
Okay, thank you.
I kind of should have done the order on this because you've kind of already answered the question. Let's move on to the
Well,
treatments.
let me tell you, Bryce, let me tell you a little bit about the difference in treatment. I was talking about
Okay.
the transition from a patient before they intubated. The difference in ICU from a septic patient, which we treat almost every day in intensive care, who is ventilated. Normally, they are ventilated for 2 to 3 days, and normally a septic patient is ventilated to protect their airway. They become hypoxic, so they get intubated and ventilated, and they have hypertensive issues. So they need antibiotics, they need pressors, but that will go on for about 3 to 4 days, sometimes 5 days. In gross septic issues with lung issues like severe pneumonias, it could be a longer time. Then they could end up being the longest time. Normally, we keep somebody with a tube in their mouth, in their throat, about 14 days. Then they transition to having a trach. But that's a normal situation. In these patients, these COVID patients, they've been ventilated for a month, almost 2 months, 6 to 8 weeks.
Wow.
That's all, and that's the huge difference. So plus all the supportive care, antibiotics, because they do become run into septic issues the longer they're on the ventilator because of pneumonia, and also any hospital-acquired infections that can occur with just being ventilated. Okay, and that's the main difference.
Now I understand, and you can correct me if I'm wrong, but the major infection that kills COVID patients is bilateral interstitial pneumonia. Yes,
and at that point, the COVID, some papers have called it the lungs lock up. They become ARDS, where the lungs get very difficult to it's called acute respiratory distress syndrome, where the lungs become increasingly difficult to ventilate. This is why the paralytic, this is why the high dose sedation, to try to decrease that, therefore getting maximum oxygen to the lungs. So, wow. And that's why the proning and trying and maintaining the alveoli at one point we would do what's called PEEP, keeping the alveoli open maximum. But now sometimes with the COVID patients, keep the alveoli open constantly, getting maximum air to the alveoli on the ventilator. This is a special mode on the ventilator, which I will send you some information which you could pass on to them later on about that.
Yeah, but basically you're putting pressure into the lungs to keep those alveoli open.
Correct, and not, yes. Normal ventilation, the alveoli do open and close. We use a small amount of PEEP where they open and they stay open just a little bit longer. Okay. But the longer they stay open, is the more fluid can get into them, and the more issues with the more difficulty to breathe, and fluid buildup in the lungs, causing increased atelectasis.
Yeah, I've seen X-rays of COVID patients, and basically it just looks like a whiteout.
And that's exactly what happens, and almost from the get-go.
Wow. Let's talk about some drugs.
Yes.
Yeah, I won't talk about the hydrochloroquine or any of that.
I'm not me personally, but it definitely the cause of the arrhythmia, the fast heart rates.
Okay, Hilbert, hold on a second. Yeah, your internet got a little behind. It was cutting you off. So try that again.
Okay. Yeah, we talk about that chlorine drug, but it did have issues with the increased heart rate. And that's all I'll say about that.
Okay.
But we have
You guys are having quite a bit of success though with the dexamethasone.
Yeah. And we have used even before the patients even become they have had doses of donated plasma. And all should just be trying to decrease decrease them getting on the ventilator, and if they're on the ventilator, these drugs can decrease the time.
Okay, we're having a little difficulty with the with the audio again. I think it's just your internet slowing down a little bit, so it's kind of cutting you off. I don't know. We'll give it a second. Maybe it'll catch up.
You with me? You hear me?
Yeah, I got to note that the audio is kind of bad, and I think it's the internet. Still kind of cutting out. Let me try something else and see if I can. Don't know if this will help or not. Okay, try it again, Hilbert.
Is it any better right now? Can you hear me? Hear me better? Any better?
Okay, I'm going to mute myself when you talk, Hilbert, and see if that helps any. Go ahead.
Okay. We were talking about using the remdesivir and dexamethasone. We have used these drugs. We have given patients before how they are being supported here, before they are regulated. And the point being is to prevent them from getting to slow the course of the virus. And when they do get the ventilator,
okay, we're still having a lot of problem with your audio, and I'm not sure why. Try turning your camera off, Gilbert. Turn your video off for a moment. Down in the lower left corner, there should be a video. If you click on the video, it'll turn your camera off for a second. I think we're overwhelming your internet is what we're doing.
Yeah, probably.
In the lower left-hand corner.
Yeah,
just like that.
Okay, can you hear me better?
Oh, I hear you much better now.
Okay. So,
all righty.
I'll go back to talking about using the remdesivir, dexamethasone, and donated plasma. So we have used all three. We are using all three drugs, hoping to reduce and slow the virus in patients who have not gotten on a ventilator, and the ones who go on a ventilator to decrease the time spent on the ventilator. And that's those are the drugs to support the virus, not cures, but they're supportive care. Other drugs are supportive care, blood pressure, pressors, Levophed, other drugs, propofol, sedation, and Nimbex, normally for paralytics, and morphine, continuous morphine for pain, and antibiotics as so described by our infectious disease doctors.
Yeah, I wanted to, maybe you could help me explain for people who are not familiar with the ventilator, why we paralyze them when we put them on the ventilator.
Once again, we paralyze them. So Nimbex is a neuromuscular paralytic, also a skeletal muscle relaxant, thereby reducing and paralyzing the muscle walls, paralyzing the patients. So their effort, because if this enough sedation isn't working, then the paralytic will help them help their muscles relax chemically, so thereby getting more oxygen to their lungs and maximizing their ventilation.
Yeah, I know we used to call it bucking the vent when they would,
Well,
they would
yeah,
try to breathe over the ventilator.
And that was before we used propofol a lot. In those days, we used Versed and that. Now with propofol, less often we need propofol, but now in these patients, they are needing, most patients can be sedated on 15 to 20 mics of propofol. These patients are needing up to 80 mics of propofol, which is a high dose of sedation. And this is almost like 12 days into the disease on the ventilator. It's extraordinary. It's everything about this disease is extraordinary.
Yeah, you don't hear that in the news.
No. Are you with me?
Let's see, moving on. Is there any attitude as far as, or any opinion as far as testing goes, how the staff feel about the testing issue?
Well, I can't get into this too much in the public arena. Every hospital facility has have their protocols of when and why to test us, and we can be tested if we have an incident where we think we've been compromised. There's testing in the community, which is to some degree, we do rapid testing on all our patients coming in who are compromised or who to the ER who we think who are symptomatic and are compromised. And that's when either they were tested and positive in the community and their symptoms got worse while they were quarantining, or they came in with symptoms and they were tested positive, then they would isolate them to the COVID unit.
Okay, I think you pointed out earlier, and I'm going to point it out again for everybody, that you're in a very highly agricultural area.
Correct.
A lot of migrant workers, a lot of families living together because it's the only thing they can afford. A lot of close contact in that community.
Yes. So this is our community. It's a family-oriented. I mean, this is a family, the Hispanic community. So we often, we are using a video. We have been employed a number of translators, and they come into the rooms with the video monitors. Even though the ones who are not intubated, they can speak via video to their families as often as we can. And the ones who are ventilated, the families can see them on the video screen and still talk to them. We try to do that once a day. And if their condition changes, we try to have this family speak to them. And we try to make that a very important thing for us to do, to value their family situation.
Yeah, I'm gonna point out for everybody the video that Hilbert's talking about. They'll have a portable computer, and somebody might be sitting in Houston, Texas, or wherever. We can bring a translator up on the screen, and it's just like they're there in person. They see the person, they hear what they say, they translate it, repeat it back in English to the staff, and they have 100 different languages they can do for us. So it's really a handy tool.
Yes, and that's all we can do because visitors are not allowed in the hospital at this time.
Wow, that's got to be tough on the families.
Yes.
Moving on to the next one. And I think we're getting near the end of our questions here.
Mhm.
I wanted to ask you a question, if you feel appropriate to answer, but of the patients that actually go on the ventilation, how many do you actually see come off the ventilator?
Well, we have had in the beginning, in my unit, there's specific numbers for the whole country. Presently, we have had about 4 to 5 patients come off the ventilator and go home. We started off in the first few weeks having 2 patients. In the last month, we would be gone to having 4 to 5 patients. And so I would say between 3 out of 5, I just as in my unit, not speaking factually for the whole country.
So about 3 out of 5 would actually come off the ventilator?
Yes, and recently, this also changes, and we've had a number who have not. More so of the 5 we've had, we've lost 4.
Yeah, I don't know what the national statistics are either, but
and
I know they're worse than 50%.
Can be looked up, but this is just how it's been, and but we've done. I think we've done well. Our nursing care, our pulmonologists have been amazing. Our respiratory therapists are amazing. So it's the supportive care we give, and if they respond, and some have gotten better, and have gone home. I mean, people have lasting effects of some shortness of breath. If they were on paralytics, there's some initially some delirium, weakness in their limbs and muscles, and they needing some physiotherapy, and those are the long-term effects. They suggest usually some people have a 2-week recovery, and in some phases they're saying if they can go, if they can have a 7-day without no symptoms, they consider recovered. And in some instances, if they can do 2 treatments, 2 negative COVID tests in 24 hours and a negative, they can consider recovered.
Okay.
That's a national statistic.
I know they've been talking a lot about, impacts other organs like the kidneys and the liver and so.
It does. Some patients have gone into renal failure and needing hemodialysis or bedside dialysis, yes. And some patients have had blood clots, and that's been a problem, and we've had to be on blood thinners for a duration of time. And we've seen everything that has evolved with the disease in the media, on the news. These things are real and do happen, yes.
Yeah, there's no hoax about it.
No. So the team, the nurses are amazing, and I can't tell you how tough it's been. I have helped out a lot. I have not spent a lot of time up there, but I do go help. I've been with the patients. I've seen them. I see them a lot, and it is the toughest thing in my career. In all these 40-some years I've been doing nursing, it's the sickest people that I have seen.
Wow. I'll go ahead and open it up. I want to point something out just before we leave this picture here. Notice the surgical caps the nurses are wearing.
Yes.
And notice they've sewn buttons on the side for the mask to take the pressure off their ears.
Yes, some people find the mask after time, the ears become irritated because you're wearing the mask literally for 12 hours. Some 16 hours, depends how long we work. We've had a lot of staffing issues because we have to maintain care. So, and it's been tough staffing decision because these patients take so much care.
Yeah.
A lot of high impact on our nursing staff.
I bet there is. Does anybody out there have any questions that they want to chime in and ask Hilbert?
So my question, it's kind of my family's been on a warpath with me to try to keep pushing down the alternative facts. How do you guys deal with that kind of like attention? People saying, well, this is whatever all my this is what a doctor in Florida says. This is what a strip mall doctor in Texas says. How you guys deal with people trying to bring the alternative facts and try to, I don't know if you understand what I'm trying to say.
If you saw the nurse speaking in the video we introduced with, trying to reinforce to the public how real this is. Those are the words you have to keep saying to them. The virus is alive. There is no vaccine, and if the people fail to, it's just no real good answer. It is clear to me. It is simple in working in the field, and even if I wasn't working in the field, it would be simple. There is a virus that's killing people, and the things that we can do in the public, masking, hand washing, those are the things that we can help to reduce and the disease from spreading. There is no one easy answer for that question. You just have to keep saying that the disease is real, people are dying, and if you fail to wear your mask, you can get the disease. And this happened with AIDS back in the day. Until people's mummies, brothers, sisters, kids started to die, people did not believe AIDS. So that's all I can say on that.
I have a couple tools, perhaps, that might help, Trevor. And one of those is the number of people that have been tested so far. We're looking at a small percentage of the population. Now, they estimate that our testing is maybe only getting 10% of who is actually infected. But if you took the numbers tested positive and multiplied it by 10, you're still only looking at about 10% of the American population. 90% of America has not been hit by it yet.
Yes.
That doesn't mean they're not going to be. I mean,
Correct.
It's still spreading and there is nothing stopping it. We will eventually hit a point where 20% of America, 30% of America, 40% of America has been infected. And it's not going to be until somebody out there saying, oh, this is a hoax, until one of their family members gets infected, then suddenly it won't be a hoax anymore. So we're at the very beginning of this pandemic. We're not at the end. We're at the beginning of it. So,
yes.
And what I would also like to say, if they bring up the subject of miracle cures, the gold standard for all testing of all medications is a double-blind placebo test.
Correct.
The double-blind placebo tests have shown that hydrochloroquine doesn't do anything. The only ones that are showing it does are those who just happen to give it to a bunch of people along with dexamethasone and others, and they get better. That's anecdotal evidence. That's not valid science.
Right.
You have to have any study that has to be a double-blind, placebo-based study in order to be valid. I don't know if that helps any, but
no, it does. I appreciate that.
Okay.
Appreciate
Yes. And we are a good ways away from getting that. Right now, we just have to maintain the basic precautionary standards of protection.
The reason they want to test so much is if we can, the virus has to have some place to go.
Yes.
If a person gets a virus, they will either get better and beat the virus, then they're not contagious, or the person dies. But during the point while they're contagious, as long as there's somebody there to pass the virus on to, this will continue.
Correct.
You have to create a shield around those people who are contagious with either no contact with other people or only contact with people that are immune. That's what the herd immunity is all about.
Right.
If I have COVID and I walk into a room with 10 people and all 10 of those people are immune, the virus is going to die with me and it won't go any further.
Correct.
Unfortunately, most people are not immune. So it's still passing from person to person to person.
Yes, and we don't know if somebody becomes, we don't know if somebody has some immunity. We don't know the length of time it's lasting. It is too new to know all this. We won't know this for a year or 2 years to come, the length of time immunity is lasting. Even when we do get a vaccine, we have to see before the vaccine hits the market, people will have to be tested and see how long they have immunity from the vaccine. It could be, we just don't know yet.
There is some good news coming out, and those of you in my MedSurg 1 class just studied this. What cells produce antibodies? This is going to be on a test question. Anyway, B cells. B cells produce antibodies, and we're worried because the antibodies, after someone gets COVID, the antibodies drop off after a while, which means your immunity goes away. And that's what's scaring everybody. But what other cell in the body produces immunity?
T cells?
T cells. You win, Megan. You win. They are beginning to discover that a T cell immunity lasts a lot longer, and they're beginning to discover that people that were exposed to a coronavirus of another kind, like say a coronavirus head cold, actually have a T cell resistance to coronavirus. So that's good. That's good. And that could explain why some people never even know they had COVID, while other people get deathly ill. So there's some really good research coming out right now, and that would mean we don't need 60% of the population for the herd immunity. We might be able to get away with maybe 10 or 20% of the population developing immunity in order to develop this herd immunity that we need in order to stop the virus from spreading. So there is some good news out there, but it's too early to tell.
There is good news, but everybody has to be on the same page. And until we are on the same page, this will not slow. And that's as much as I can say on it.
Yes.
And I hope this gives people a little insight into what nurses are doing all over the country in ICUs who are more impacted than my unit, and are going through daily. The doctors, the respiratory therapists, and the respiratory therapists are amazing. They have raised their level of care, their level of thinking, working the ventilators to the maximum. The things we're doing are evolving daily as new studies come out to treat these patients, to try to give them some hope to save their lives. We are working tirelessly. It is hard work, but we enjoy it, and we try to give the best care we can with the resources we have.
May I ask a couple of questions about the meds?
Yes.
So one of them, you mentioned that you have a protocol of antibiotics that you incorporate.
Well, it all depends. Depends on what microbiology shows. Infection-wise, our infectious disease doctor is on all the cases, and the most common broad-spectrum antibiotic for most pneumonias, which is supportive care, is Zosyn. But it all depends on what other things are going on with the patient, what things grow out.
Also, when you were referring to the antibiotic, you were not necessarily. You were referring to the pneumonia that develops while they have.
Correct. Yes. As the longer somebody is on a ventilator, the longer sepsis protocol sets in, and infections may set in. So that's why you treat all these symptoms and to to continue to give them the best outcome.
Okay, and then the other question that I had was, I'm not sure, I know I got the dexamethasone, but you also mentioned the one that starts with an R, and I looked it up. It's been around since 2009.
Remdesivir.
Yeah. So, I mean, look, what opportunity have you guys taken to, I mean, are you sending your statistics out to show the outcome with that particular drug, or is it just?
I believe all the health authorities in all the in my county,
Yeah.
they are reporting all their statistics. So Monterey County Healthcare is online, and we have some very good articles there of our statistics.
What's it called?
Monterey, Montrey, Monterey County Health Department.
Okay. And then one more thing about drugs was, and I'm not familiar with what you do, obviously, but two things. What is the drug that you use to paralyze the patients to allow them to respond better to the respiratory therapy?
One drug is called Nimbex, and you could look it up. Like I said, it's a neuromuscular drug. It's also used in anesthesia. It's also a muscle relaxant.
Well, that one's fairly new, isn't it, Hilbert? Because I don't remember that.
Nimbex, it's newer. Yes, it is newer.
And then just from one more question, if you don't mind, I thought it was interesting, and I think it's a good idea that you guys changed them from supine to prone. I'm sure you probably take it partially. I mean, you may not go directly from supine to prone. Is it a partial movements to allow that, take advantage of the lungs having opportunity to?
It's not every patient, it's the individual patient. It depends how they're ventilating. If we have trouble ventilating them, we will, the doctor will consider proning them to see if we can maximize their oxygenation and their ventilation. And sometimes it's effective, not always, but we go to that mode and other modes on the ventilator everything is geared to maximizing the lung ventilation, and so therefore hoping we could decrease the oxygen needs as time goes on.
Does your unit have specialized beds that allow you to reposition them to protect their skin when you're doing those sort of things?
Well, all our beds have built-in mattress aeration, but we turn our patients every 2 hours, or we can put our bed in a rotation mode that slowly rotates them from side to side gradually. And we set it, yes.
Is there any advantage of having them? I don't know how bad it looks. I've seen people in a nursing home setting who obviously they weren't as bad as what you're experiencing. So I'm just presuming that the therapies don't come in until after, one, because you don't want it to, cross contamination, but for positioning, I guess what I'm asking is, do you bring them into an upright position, or is it just?
No, we keep them in normally they're 35 to 40 degree supine sitting up position. We turn the patients, physically turn them from side to side, which is good for their skin and for the lungs. And also we put the bed in rotation, so the bed is continuously turning them slowly in a rotation from side to side.
Yeah.
And it does take help each time. It takes 2 nurses to go in the room to turn the patient. So this is why it requires a number of nurses taking care of these patients. But yes, but they are physically turned. We pay. Looking after the care of these patients, everything you've learned from day one in school, in your labs, skin care, skin protection of bony prominences, everything you learn to observe about a patient, when you do your assessment, your head to toe, your assessment, your lungs, everything you use in this patient every single day. High level of care, but there's no low level. Everything is important to maintain these patients, to give them the best outcome possible.
And then the blood clots, of course, is related to just the fact that they're stagnant. I mean, not moving much. I see you said renal failure.
We believe the new symptoms of blood clots is correlated to the COVID-19.
The COVID-19 is the blood clots related to that particular virus?
We believe this is so. I can't, there's new science. You have to look into the science of it. Bryce could explain that a little bit better to you. Okay. But we believe patients who have COVID have gotten blood clots, and we believe that. The science is out there right now. It's still being studied.
Okay. There's a great deal of the blood is literally thickening.
Oh, I see.
COVID patients.
COVID-19 attaches itself to the blood cells.
Oh, wow.
I'm not sure exactly if they know exactly how it works, but it
does. It is being studied as we speak.
But if you have a thickened blood, you'll have an increased chance of blood clots.
Right.
And also that thickening blood is going to have a hellacious effect on the glomeruli of the kidney. So that would explain where the kidney failure could be coming from.
Patients.
Pardon?
Might be a super ignorant question, but what's causing it? I guess I know what's causing it, but like what's in the blood that's making it thick? Like ketones? Like, do you guys know?
Like cytokines or something like that?
Or what is in why is it becoming thick, I guess?
I don't know. Hilbert, do you know why?
I don't know. To give you a good answer right now, but there are some very good articles out there right now. I will have to find them for you, but it's not necessarily, I mean, using the word thickening is not scientific enough, but blood clots are formed in the blood. The exact why, you will have to look at the new studies, COVID related, but people do get blood clots also from being sedentary, and patients who are not moving, who are not getting, their limbs are paralyzed and blood is pooling. All these things can cause blood clots in most people who are in bedridden. This can happen. So for all these reasons, alongside why we're seeing them in COVID patients, I don't have that exact answer, but we are seeing it.
So okay.
If we don't have any more questions, I wanted to thank Hilbert for being here. He's a very, very busy person.
Yes, thank you so much.
And
very welcome.
Guys are our heroes, whether you want to be or not. I'm afraid you guys already are.
I will send Bryce some links of some information as far as the respiratory care is, and a good video from Frontline. I'll send him the link for you guys to pull it up. It talks about COVID in our agricultural patients in the valley over here. I will let him know, and then he'll post it for you in the near future.
Thank you.
You're welcome.